Hi everyone, Big Papa Scott here. Figured we had talked a little bit in a previous video about the electrical system of the heart, but I just kind of touched on it, so I thought maybe we could explain it a little bit more in detail. A lot of people have trouble with the electrical system of the heart. They can have extra heartbeats. Some of them are called PACs, which is premature atrial contraction. Some of them are called PVCs, which are premature ventricular contractions. And there's forms of heart block and other things that can come up that can cause trouble. The rhythm has to be, at least a life-sustaining rhythm. So if you've ever heard of things like atrial fibrillation or other things, people can live with those. It's just that their heartbeats are probably not going to be regular. They do have to have a little bit of a blood thinner because of that. So anyhow, this picture I have here is what a real EKG rhythm looks like. This is one beat. Okay, so this isn't a whole EKG. This is just one beat off of an EKG. Now there are several components of this. So when you see a straight line, that means the heart's resting. Okay. This P wave, which is what we call it, represents the initial electrical activity in the heart, the very start of it. And what that does is that kind of fires through the atriums, which you remember are the top two chambers of the heart. And that makes the atriums contract a little. Even though they're not loaded with muscle, they have enough muscle in them to help them contract and push some of the blood into the ventricle. That P wave is that contraction, or actually just after it is the contraction. And then as it goes into the other node of the heart, this is represented by the SA node, which I'll show you in a picture in a little bit. And then it goes to the AV node, which is probably about here. And then this thing, the QRS, is the actual contraction of the ventricles. So that's the pumping chambers squeezing and pushing blood out of the bottom of the heart and throughout the body into the lungs. And then the heart is kind of still or refilling with blood, and in this portion here is called the T wave, and that's when the heart kind of recharges itself. And then you would have another P wave. Boy, that's a terrible P wave. And then another one of these, and then another T wave. And obviously the person who drew the first one is a lot better at it than I am drawing it. But that's how an EKG kind of works, or the parts of a heartbeat work. This is called repolarization, which is a fancy word for recharging itself. And it gets the heart ready for the next beat. Now, all these become compressed when your heart rate goes up. So if you're on a stress test or treadmill, your heart rate goes up to 160, sometimes it's even hard to see the P wave and the T wave. They get so close to the QRS, the big part of the ventricles contracting, that it can be hard to see them. So, but it's still normal. It's just that sometimes when the heart rate gets up high, it's hard to distinguish those things. So I just wanted to show you that first off. Now, if someone says they're going to do an EKG on you and you look like this after they hook you up, get up and run away, okay? Just a quick piece of advice. Now, when you go to the doctor and they order a real EKG on you, this is what you get. You get a 12-lead EKG, which allows the doctor to look at different areas of the heart and their electrical activity. So each one of these areas, like down, it says V, oops, sorry folks, hold on a second. Like right here it says V4, V5, V6, and then you can see the other ones, V1, V2, V3, and then all these other ones. Each one of those represents an area of the heart. And like the three that I circled are mainly the ventricles of the heart in the ventricular area. I'm trying to remember what part of it, but my expertise was not EKG, it was echo. So, and there is a difference between the two. An EKG takes about 5 minutes, and echo takes significantly longer, and we can see a lot more things with an echo. But it is important because a lot of times when you come in, if you're having chest pain, the first test you're going to have is an EKG. So that's to determine, an EKG will show if you're having a heart attack. And the way they can tell is if, let's say this one, 2, 3, and AVF are showing this real either dipping down or going up of this particular wave right there. This is a heart attack, and this is ischemia, or you're about to have a heart attack. So they look at that, and in this particular series, these three leads would be an inferior wall heart attack, which is kind of on the bottom of the heart. If you were to cut it, slice it, like from the right hip to the left shoulder, and you were looking directly into the ventricle, it'd be on the bottom left of the ventricle. So it's a good way of telling right away when the patient gets to the hospital whether or not they're having a heart attack. Now, one of the other things I wanted to show you was people do have some other things that come into play. Hold on a second. One of the other things we do see is extra heartbeats, and this whole line here, right here, this is all the same, section of heart beating. This is just, one section or one printout of the heartbeat, and right here you have 1, 2, 3, this is a fourth one, 5, 6, 7, 8 heartbeats. So that's all they really need to determine whether or not you're having a heart attack, or and it's an emergency situation. This part that I circled here is an extra heartbeat, and this one looks like a PVC, but it could be a blocked beat too, but I'm going to go with PVC. And if the doctors out there want to challenge me, that's okay. I can't see them, and I'm retired, and I don't care. So this is an extra heartbeat that its origin is from the ventricles, or the bottom of the heart. Now remember, when I told you in the previous video that the heartbeat, it originates in the top of the heart, and that's the normal heartbeat. So that would be like one of these. This originated in the top of the heart. And so did this one over here. That originated in the top of the heart, and that looks like a pretty normal beat there. So this one here in the middle, though, is an extra beat. So you can see it falls in between two regular beats. It actually prolongs it a little bit, but it does fall in between them. So that would be something that we would note, saying the patient's having PVCs, and sometimes that can be the reason why someone is having some anxiety or chest pain or anything of that nature. It also can mean that there's starting to be a rhythm problem with the heart. So there's a lot of issues that can go along with it, but a lot of times if that's the only thing we see, we don't have the patient worry too much. So anyhow, now this printout I put here, this picture I should say, is what's called the R to R interval, and this is how we calculate what the heart rate is. And in the old days we used to count the boxes. Each box represented a certain amount of time. I think it's 0.5 milliseconds. I can't remember exactly. It's been a long time. But you can then calculate what the rate is by counting the boxes, and you might come up with a rate of 60 or 80 depending upon what the patient is having. The good thing about today's machines is it tells you right on top that the rate is, let's say, 72, and it'll also give you the patient's name and all the other good stuff, where back in colonial times when I was doing EKGs, you didn't get all that information on the top. So it is the way that we used to count the heart rate, and now we get to have that easy printout in the front, and it's a good way of showing it. But this is also showing the P wave and the main heartbeat, the QRS, and then the T wave, which is repolarization, or, like I said, the recharging of the heart. Now this is a picture of the inside of the heart, and you can see these are basically nerve bundles that go through the heart and send a little shock through the heart and cause it to beat. This is the sinus node, which, if you remember right, I told you that P wave that was in the beginning, and then there was a QRS and a T wave. Well, this represents this. So when that sinus node fires, you'll start to see that P wave. So what that does is that's the origin of the beat. It sends an electrical signal, down this pathway here, and then down these pathways to right here, which is called the AV node, which is the atrioventricular node. And then that is just about when it sends it to here, which is called the bundle of His. I don't know why that's what they call it, but it's the start of the ventricles contracting. And what happens is it sends the electrical signal down and into the right side of the heart, down into the left side of the heart, and then the heart squeezes and the electrical activity leaves and goes back up. Well, it doesn't go back up, but the SA node, the heart recharges, and the SA node then fires again, and you get another beat, and another beat, and another beat. All those can be done, thank God, without us even knowing it. So there's one other thing that they put on here, and it's right in this area here, called a heart block. And what it's showing is there's a little bit of a break between the nerve there, and that can be caused by a heart attack in that area that will cause the nerve to die there. And then the heart, it can also just be caused because you can be born with it that way. You can be born, with the nerve not connecting there. But what does happen in that case is that the nerve kind of reworks its magic and grows in a different direction and then reconnects with the rest of the electrical system that goes through the left ventricle. What happens then is you get a little wider QRS in the middle of the EKG. So does that really mean anything? No, it's just something that the doctors put in the report saying you have a little bit of a heart block. Now, if the heart block is a severe heart block, which can be a third-degree heart block, which is when the block is so bad that it's basically blocking off almost, the whole signal going down to the rest of the heart. There will only be the QRS will be, very wide, and then you don't even see a P wave. Well, if you see a P wave, it's irregular, and it's not really working. So what ends up happening is those are cases where sometimes they have to go in and figure out with a catheter what's causing it and see if they can fix it with a procedure called ablation. They don't always use it for heart block. They use it mainly for arrhythmias, which are extra heartbeats. But if a patient has a lot of these PVCs or extra heartbeats, they can go in with a catheter that comes up the aorta and then goes into the ventricle here, can go into the atrium too. Depends upon where they want it. They can cross this atrial septum and go into the right side of the heart. If they think the origin of the extra heartbeat is right here, they can burn that area or freeze it, depending upon which procedure they're using, and then that stops the extra heartbeats from going on all the time. So you get a nice normal rhythm like that. So that's called ablation. It's a very long procedure. You have to lay on a table for quite some time, at least most of the time. Every once in a while the doctor gets lucky and hits it right away, but a lot of times it's just a trial and error thing. So, but anyhow, that's a quick and dirty, well, 15 minutes worth, sorry. It's always longer than I think because I'm always running my mouth too long, but it is an explanation of the electrical activity on the heart and how it works. And we'll let it go at that. And next time we'll talk about maybe a little more about the heart. I think we'll cover some of the things that you see in pediatrics and a few other things. So we'll see you then. Bye.